summer, we're going to talk about the care of our complex patient case study. We have our case, and it's on Mrs. Rosalind Jones. She's a 74-year-old woman who arrived at the ED by ambulance after experiencing a ground fall at home. The patient stated that she felt dizzy and lightheaded and had a terrible headache. She has a history of hypertension, COPD, and depression. Her daughter was accompanying her and said that she suddenly lost her balance and seemed a little confused. And she also said she was having a little bit of difficulty with her speech. The patient lives by herself, still drives, is recently retired. She smokes a pack of cigarettes a day and has for the last 25 years. She denies drinking any alcohol. Upon assessment, the patient's heart rate was 102 beats per minute. Her respiratory rate was 20. Her blood pressure was 140/90, and her temperature is 99 degrees Fahrenheit. The patient had difficulty stating her name and birthplace, as well as not being able to accurately state where she is. The healthcare team immediately began to suspect there was a stroke, so the patient was taken immediately to radiology to get a CT scan. Blood was then drawn and sent to the lab. While waiting for the results, they performed an NIH stroke scale. She scored a 2. It is revealed that the patient is experiencing an ischemic stroke. Thrombolytic therapy was initiated immediately. Some critical thinking questions that we have are: what risk factors did the patient have, which are modifiable, which are non-modifiable, and how can the nurse educate the patient regarding these risk factors? So as we know, our patient has hypertension and is smoking, and those are modifiable risks. Some other modifiable risks that might not be present would be a sedentary lifestyle, and if she was falsely denying the consumption of alcohol. Some non-modifiable risks would be age, gender, and race. Regarding these modifiable risks, the patient can do some things simple, such as creating a healthier lifestyle. I know she is older, so sometimes it's a little bit harder to accurately change your lifestyle, but some things like smoking cessation or even changing your diet can improve your outcome. There is a diet called the Dietary Approaches to Stop Hypertension, also known as the DASH diet. This diet includes high fruits and vegetables, moderate and low-fat dairy products, and lean animal meat. And the other diet that showed to decrease the risk of stroke was the Mediterranean diet. Next question: what interventions can the nurse help the patient implement to maximize self-care in the recovery period? Nursing care overall has a significant effect on patient recovery. When a stroke occurs, many of the body systems are impaired as a result, so fast and efficient care can prevent life-altering complications. There are multiple nursing interventions that can improve the recovery period to maximize self-care in a patient diagnosed with the stroke, and this can be discussed with the patient and her daughter. The nurse themselves can actually assist the patient in improving motility, improving communication, enhancing self-care, adjusting to physical changes, assisting with some nutritional needs, and even improving thought process. The next question: using your knowledge of the FAST acronym, which assessments are priority for this patient? So using the FAST acronym, you're going to assess the face. You're going to ask the person to smile and see if one side of the face is drooping. The next is arms. Is the arms and legs weak? So you're going to ask the person to raise both their arms in front of them, and if there's one of the arms that's proceeding below the other arm, then that causes that suspects arm weakness. Difficulty to speak. So you're going to ask the person to say something simple like "the sky is blue" and have them repeat it. If they repeat it and it's a little bit altered, then you know that it's time to call 911 and get help immediately. Some evidence-based practice that we found regarded the clinical presentation of the NIHS stroke scale. So that's the National Institute of Health Stroke Scale. It's a rapid assessment for the documentation of clinical progress in patients presenting with ischemic stroke. Many institutions use the NISS scale, but it is not to be used all the time with it or in place of the comprehensive neurological examination, which is crucial when you are measuring improvement after a stroke. Time management is extremely important because time is brain. With ischemic stroke, thrombolytic therapy needs to be initiated as soon as possible, ideally within 1 to 3 hours of system onset. This is because the brain loses about 900,000 brain cells every minute, and 4 million nerve connections are destroyed every minute and when a stroke happens. So TPA improves the chance of recovery from a stroke. Studies also show that the patient with ischemic strokes who receive TPA are more likely to recover fully and have less disabilities than a patient who does not receive that therapy. Another thing is communication. You want to be aware that the patient has had life-altering changes. Their communication might not be the greatest anymore. So you're going to assess for dysphagia. You're going to be extremely patient with the individual who has experienced a stroke and be sensitive to their sensory difficulties. Minimizing distractions, lowering dim lights, and even decluttering the environment can help the patient. Another thing is educating the patient on smoking cessation or even healthy lifestyle, and keeping that open communication between you and your patient is helpful. As we all know, with any diagnosis, patient safety is important, but it's extremely important in stroke because they do have a lot more weakness. So in order to prevent injury, we want to provide a safe injury-free environment. We're going to remove all hazards and make clear pathways for our patients, and we're going to assess their ability to swallow as well as how well they are walking as well. And also providing adequate time for rest is very helpful in the recovery process of our patients.
Okay, we're going to move on to the nursing process. We know that starts with assessment. And so as Ali mentioned, and as we saw in our case study, we're going to perform the NIH stroke scale. We also really want to monitor their vital signs. It's recommended that vital signs are taken at least every 15 minutes. And then we want to look at their history, their medications, their risk factors. So we do have good data on that for our patient. For example, we know that she has a history of smoking and depression. So we want to look at her medications, ask her or her daughter if she takes any medications at home, for example, for her depression. And then we also want to use imaging, especially neuroimaging, as Ali mentioned before, to exclude intracranial hemorrhage. Then we move on to diagnoses. And so we'll have our medical diagnosis. Of course, in this scenario, it's the acute ischemic stroke, but we know that we can make several nursing diagnoses. So for this patient, we might have ineffective cerebral tissue perfusion, impaired physical mobility, impaired verbal communication, a risk for impaired swallowing, which is really crucial that we recognize that, a risk for injury. So all of these diagnoses will play a huge role in her care. Next, of course, we move on to planning her care. So again, we've emphasized it a lot, doing those frequent assessments, implementing those safety measures. So taking a look at the patient's room and seeing what we can do there to reduce the risk for injury. Communication. So we know that stroke patients often have difficulty in communication with speaking. So we make a plan for that. How are we going to communicate with this patient? If they are having some difficulty speaking, how can we talk to their family members and her daughter about communicating with her? And then we want to look at our orders. So what medications are we going to be giving this patient, and what other interventions will we implement? And then the final two steps are implementation and evaluation. So doing those things that we planned on doing, like performing the assessments, implementing those safety measures, communicating well with the patient, making sure that we're in constant communication with their family, giving those medications, implementing the doctor's orders, and then evaluating how successful it is for the patient. So what goals are we trying to meet, and are we meeting those goals? Is the patient safe? Are they free from injury? How is their neurologic status developing? Are they communicating well? And then are the medications producing the effects that we desire? Are they causing the adverse effects? So all those things play into evaluation of care. Again, we're going to talk about interventions. So one more time, assessment, and just making sure we are not forgetting about those constant assessments. We're going to watch for changes in blood pressure, in neurologic status, in heart rate and rhythm. We're going to look for their respiratory rate, any changes in their pupils or in their vision. And then we're going to look at their higher functions like speech, restlessness, irritability. Changes in these things might indicate bigger issues. We may have to implement some oxygen therapy. So it's crucial that we maintain adequate tissue oxygenation with acute cerebral ischemia. We want to prevent hypoxia and potential worsening of neurologic injury. So supplemental oxygen should be administered if there's evidence of hypoxia, which we would see by looking at those blood gases, or if we see any desaturation that's detected by the pulse oximetry. We want to implement some therapeutic interventions. Something as simple as positioning can make a huge difference for the patient. Elevating their head just slightly, placing them in a neutral position, and then again focusing on their environment, making sure it's quiet and relaxing and supportive of recovery. We could do that by clustering nursing care. So trying to cluster our care so that we're not frequently in and out of rooms. And then the next part is the medications that we're going to administer. So oftentimes stroke patients will receive an antihypertensive. In the setting of acute ischemic stroke, many patients have elevated blood pressure for the first 24 to 48 hours. So we saw this with our patient. Their blood pressure was 140/90. So we saw that elevation there. When the treatment for antihypertensives is indicated, we need to lower the blood pressure cautiously because we don't want to cause hypotension. So parenteral agents like labetalol are easily titrated and have minimal vasodilating effects. So they're preferred in the treatment of cerebral stroke. In some cases, an IV infusion of labetalol or another antihypertensive might be necessary to adequately control the blood pressure. IV administration allows for careful titration as well. Patients can be treated with oral agents like labetalol or lisinopril, but of course we need to look at if dysphagia is a concern. And again, we just want to watch carefully for hypotension. We want to lower the blood pressure, but keep it in that safe range. Patients also might need insulin. We're going to monitor for hypoglycemia. This can cause focal neurologic signs that mimic stroke. In itself, it can lead to brain injury. Additionally, several clinical studies have associated hyperglycemia with poor outcomes. So prompt measurement and normalization of serum glucose concentration is important. We might have to administer subcutaneous insulin if the glucose is over 180. Antipyretics may be indicated. We saw a slight temperature elevation in our patient at 99, but increased body temperature in the setting of acute ischemic stroke has been associated with poor neurologic outcomes. This could be due to the increased metabolic demands, the enhanced release of neurotransmitters, and increased free radical production. So maintaining normothermia might improve the prognosis of patients. Again, using either antipyretics or possibly cooling devices. And it's usually indicated for temperatures above 37.5 degrees Celsius. Thrombolytic therapy, as we saw in our case, is of course crucial. IV administration of Alteplase is the only US FDA approved medical therapy for treatment of patients with acute ischemic stroke. So that's kind of the gold standard there. And then the use of anticoagulants is debatable. Data suggests that urgent anticoagulation And acute ischemic stroke patients can lead to symptomatic intracranial hemorrhage. And that would, of course, outweigh any potential benefit. So the timing for initiation of long-term anticoagulation for stroke prevention is debatable. There was a test done by the International Stroke Trial. They tested 2 doses, 5,000 units a day of subcutaneously administered heparin that was started within 48 hours of this stroke. But the benefits of heparin were counteracted by the increase in bleeding seen with it. So again, we're just always weighing the potential benefits with the potential risks, and this is one that's more risky than beneficial. Warfarin, as we know, is a vitamin K antagonist, so it inhibits the clotting factors in the anticoagulant proteins. There's no data showing that urgent anticoagulation with warfarin provides an acute benefit. They may, however, use it for prevention of recurrent stroke among patients with AFib. So long-term anticoagulants may be beneficial, and they may be prescribed to prevent future blood clots and to prevent a future stroke or other complication. But again, it's just debatable whether or not that should be started immediately in the acute setting.
When we're talking about collaborative care, we have to remember that stroke is a complex disease that requires the efforts and skills of all members of the multidisciplinary team. Nurses are often responsible for the coordination of care throughout the continuum. Before the patient gets to the hospital, the leading healthcare team member is the emergency medical technician or a paramedic. But once the patient reaches the hospital, a multidisciplinary team has to come together and coordinate closely in order to provide the best care for the patient. Most of the time, this team will include neurology. These are the people that specialize in the conditions involving the brain and spinal cord. They have an intimate knowledge of brain anatomy, function, and blood supply. They know the signs and symptoms found in stroke patients, and they know how to diagnose not only the stroke but also the stroke subtype. They're also very familiar with symptoms, signs, and diagnosis of other neurological disorders, and they're knowledgeable about stroke recovery and rehabilitation. Also included in this multidisciplinary team will be hematology. These are your experts on blood and the study of blood and blood-forming organs and blood diseases. They're concerned with the treatment of blood disorders and malignancies. Lab will also be very important. When you suspect that a patient is having a stroke, several labs should be ordered, including a CBC, coagulation test, blood chemistry test, blood lipid tests. A stroke can't be diagnosed by these blood tests alone, but they can provide information about stroke risk factors and other medical problems, which may be important for this patient. General surgery is also often involved to remove the clot or brain bleed causing the stroke. Radiology and imaging is also extremely important and most of the time involved. A CT scan is performed on most patients. These tests can show areas of abnormality in the brain and can help determine if these areas are caused by insufficient blood flow or a ruptured blood vessel or even a different kind of problem. MRI is another test that's done often, and it produces very accurate pictures of the brain and its arteries, and it can detect a wide variety of brain and blood vessel abnormalities, and can usually determine the area of the brain that is damaged by an ischemic stroke. Angiography is also a lot of times used to closely examine the blood vessels of the brain and the blood flowing through them. This looks for narrowing or blockages in the blood vessel. And ultrasound is usually used to see if there's narrowing or blockage in the carotid arteries that could put the patient at high risk for a stroke. An echocardiogram is sometimes used to see if there are any abnormalities in the heart that could lead to a stroke. And then electrocardiograms are performed routinely to detect irregularities in the heart rhythm that could lead to a clot that could eventually lead to a stroke. And then, of course, rehab will also be an extremely important part of this multidisciplinary team. Once the patient is stabilized, they're there to help the patient relearn skills that were lost when the stroke damaged certain parts of the brain, and they're there to help the patient regain independence and improve their quality of life. In order to conclude best practice for the diagnosis, treatment, and management of stroke, we studied several different research articles. One was a comprehensive overview of nursing and interdisciplinary care of the acute ischemic stroke patient. This one focused on educating nurses and allied healthcare professionals about the roles and responsibilities of those who care for patients with acute ischemic strokes. Another article focused on drug treatment for acute ischemic strokes, and then another one focused on the diagnosis and management of these type of strokes.
All right, lastly, we want to talk about Kern Medical Center located in Bakersfield, California. They made a video to raise awareness on the FAST acronym to assess for strokes. I have that link below for you, so just go ahead and click it and listen to a very fun way to learn about the FAST acronym that gets everybody involved in order to know how to assess for a stroke. Thank you.